Good evening, one and all. Dear Facebook Pure Urology viewers, greetings from Preeti Hospital. So today we have our special speaker. We are indeed honored to have Professor Anil Shrestha sir here in this platform for his talk. Today we are going to see about the stone-free rate, timing, tools, and truth, as a lot of ambiguity exists in declaring the stone-free rate. It varies from institution to institution and all that, and depending on the timing, one says at 4 weeks, one says at 8 weeks. There are different papers, and there is no conclusion on it. So we have Professor Anil Shrestha sir here to elucidate on the nuances of this topic. Let me have the pleasure of introducing sir. Professor Anil Shrestha sir is the Professor, Program Coordinator of MCH Urology in the Department of Urology, National Academy of Medical Sciences, Bir Hospital, Kathmandu, Nepal. Senior Consultant Urologist, BNB Hospital, Nepal. He is the Vice President and Chairman, Scientific Committee of NAUS. He is the Deputy Chairman, Scientific Committee of UAA. He is the Board Member, PEARLS and OSET. He is the member of International Section of EAU Endourology, and he is the Secretary General of NAUS 2023 to 2024. He worked as the Secretary General, and he is also the member editorial board of International Journal of Urology. He has organized various live operative workshops, conferences, and symposiums. He has performed live surgeries in various national and international conferences, and also has a lot of publications to his credit in peer-reviewed journals. His areas of special interest are urolithiasis, laser, and flexible ureteroscopy. So I'm stopping the sharing of screen and over to Professor Anil Shrestha, sir.
Thank you, Soundarya, for a kind introduction. Shall we start?
Yes, sir, please.
Okay. So, shall I start, Soundarya?
Yes, sir, please go ahead, sir.
Okay.
Your slides are visible and you're audible, sir.
Thank you. So, first and foremost, I would like to thank Dr. Chandra Mohan and a team of Preeti Hospital, Hyderabad, for inviting me to talk on stone-free rate after stone surgery, especially PCNL and ureteroscopy. It's my honor to deliver my third talk in Pure Urology. It's my third talk, and I am really honored to be here in this evening. So, I know Pure Urology is a platform where we discuss lots of surgical techniques, surgical videos, but the talk we have decided for this evening is more of theoretical. It doesn't include surgical videos per se. So we will be talking about what is the pitfalls or what are the problems with stone-free rate, or what we have consensus on in the regards of stone-free rate after stone surgery. So I bring greetings from Kathmandu, Nepal. I am affiliated to these institutions and organizations. I don't have anything to disclose in regards to this particular presentation. So when we talk about stone-free rate, I don't think it will be wrong to say that this is the single most important factor in stone surgery when we consider. We do stone surgery to obtain stone-free rate, to achieve stone-free rate. Of course, we have to consider other aspects like complication cost, operative duration, etc., etc. But this is the single most important factors in stone surgery. So if we do surgery and if the stone is not clear, then we generally tag that stone surgery as a failure or incomplete. So stone free rate is very, very important, or utmost important factors when we talk about stone surgery. Stone-free rate is not only the measure of success of that particular surgery, but it also is being used to evaluate the preferences or recommendations or the guidelines. It is mentioned that certain surgical procedure you should be used according to the stone size or location. So it is also used to define which surgery is better for particular case. So it's not only about outcome, it also tell us which surgical modality to choose for particular case. So stone free is not only the most important factor, because open surgeries, we have done lots of open surgeries, they carry very good stone free rate. There is nothing wrong with stone free rate with open surgeries, but these days we don't perform open surgeries, not because of the lower stone free rate, because of its invasive nature, because of the morbidity that that are associated with the open surgeries, namely post-operative pain, operative duration, hospital stay, etc., etc. That's why the balance between stone-free rate and the morbidities associated with particular stone surgery is very important when we decide which surgeries to perform for that case. So that's why I think the balance between stone-free rate and the morbidities or complications related to that procedure is very, very important. Although stone-free rate is the key outcome measurement of stone surgeries, that balance is very, very essential. So, what are the factors that can affect the stone-free status? As we know, higher the stone burden, less chance that we achieve stone-free rate. Stone-free rate can be affected as per the location of the stone as well, because we remember from different guidelines that for lower pole stones, there are certain recommendations which are not available for mid or upper pole stones. Additionally, stone treatment modalities like shockwave, PCNL, or RIRS can also differ the outcomes of the surgery. When we talk about stone-free rate, how to assess the stone-free rate, when to access the stone-free rate is very, very important, but unfortunately, we don't have consensus on that. So defining any patient or any procedure regarding stone free is very tricky. I think we don't have consensus on mainly three questions. What is stone free rate? How do we define stone free rate? When should we tag or when should we tell that the patient is stone free? Is it right after the surgery or after weeks or months later? So timing is also not very clear. And how do we investigate, or how do we tag, after which investigation we come to conclusion that the patient is stone free or not? So these are some unanswered questions when we talk about stone free after stone surgery. So before going to each of these questions, let's discuss why SFR assessment is important. Because as we just mentioned that stone free is very vital parameter after stone surgery. So surgical success depends on the stone free rate, and subsequently patient and surgeon satisfactions also is closely related to stone free rate. Additionally, stone free rate is very important to know whether the patient will need any re-intervention or auxiliary procedures or not. Also, will it also will tell the prevention or anything that we can do for prevention of the renal damage, or should we wait and watch the patient without doing any auxiliary procedure or not. Otherwise, in other words, should we avoid any unnecessary auxiliary procedure or not? So for these reasons, I think all the patients undergoing stone surgery should be assessed for stone-free rate. So let's jump into the first question, that is how to define stone free after stone surgery. So what is stone free rate? When do we call stone free rate? There are various reportings in literature. Some say that if the fragment size is less than
Anil,
4, yes, Chandra.
sorry, I just joined. I was in surgery. Sorry, I don't
No
want to miss
problem.
your talk.
No problem. Good
Good
to see you,
afternoon,
Chandra.
everybody.
Yeah.
Anil is my close friend. He is very good and research work in suction recently. Pan world, he is known and he has written papers in association with OSET. Sorry to interrupt you. I want to listen.
No,
I
no
joined.
problem. No
Thank you.
problem.
Sorry, please
No
continue.
problem. Okay, so we were talking, Chandra, that there are some problem with defining stone free. I'll just go back two
Oh,
slides back.
okay, please.
So there are few questions when we talk about stone free that are being unanswered. So how to coin the term stone free? When do we tell that the patient is stone free? Which
Yeah,
modality of imaging should be used and when it should be used? So, in literature, there are various definitions of fragments that we tell that the patient is stone free. Sometimes we say that if the fragment is less than 4 millimeter, then we consider it as a stone free. But some are very strict or stringent that it should be less than 2 millimeter or 1 millimeter. Or there are reports that there should not be any fragments, or zero fragment rate is also being popularized these days. So the term stone free rate, is it not equal to fragment free? That means if there is some fragment, do we still call them stone free or not? So these questions are being remained unanswered. So let's talk about significance of residual fragment size, because there is no consensus till date that no fragments should be left to tell the patient is stone free. Still, vast majority of reportings or publication, they define stone free with certain fragment size. That's why this fragment size matter. Let's see something on fragment size now. So we all know that clinically insignificant residual fragment, the terminology called CIRF, which was initially reported in 1986 by Kolb et al. But this term was basically reported fragment the stone. We don't take the fragments out actively. That's why if the fragment size is equal to or less than 4 millimeter, and if it is not causing any symptoms, or it is inside the pelvic calyceal system after primary treatment modality, then we tell it as a clinically insignificant residual fragments. But with the emergence of other surgical modalities for stone surgeries like PCNL, mini PCNL, and ureteroscopy with suction, nowadays, the term clinically insignificant residual fragments is fading away. People, they don't like to use the term clinically insignificant residual fragments because of various reasons. There is no global consensus when we should clinically insignificant residual fragments. But the points that I've mentioned, less than 4 millimeter asymptomatic, these are the most commonly used terminology. In 2020, Bhaskar and group reported that clinically insignificant residual fragments is unacceptable terminology. Rather, we should use clinically acceptable residual fragments. But somehow this terminology is never used outside this particular publication. So we don't know should we use clinically insignificant residual fragments or not. or when do we call that residual fragment clinically insignificant? Because I'll come with the fragment size later in my slides. So there is another interesting, because CIRF is a very confusing terminology, especially in this era. So there was a survey conducted among 395 urologists in mostly in North America, and the perception of CIRF among urologists is very heterogeneous. It's very bizarre. Most of them thought that the CIRF is when the fragment size is less than 5 millimeter. And some even thought that there should not be any fragment to call it clinically insignificant residual fragments. Another very interesting and very nice systemic review and meta-analysis from Eleanor and friends. So they compared fragment size and the natural history of those fragments, residual fragments after stone surgery. And what they have found is if the fragment size is more than 4 millimeter, then the reintervention rate is higher. But as we know, as we think that large the fragment residual fragment size, then the progression of disease will also be there. But according to this systemic review with more than 18 papers involved, even the larger fragments, more than 4 millimeter fragments, they are not different in terms of progression. What does that mean? That means that even smaller fragments, less than 4 millimeter, they can progress in the future and may need reintervention. So size of the residual fragments doesn't dictate or doesn't tell us whether it is going to progress or not. So according to these authors, the term CIRF is useless and it should be abandoned. I think it's a very strong statement. And yes, with the time, we are using less and less terminology of CIRF these days. So what is the problem then? So the problem is we still don't know when we tell the patient is stone free. Is it when the stone residual fragment of 2 millimeter is there, then we call stone free, or 4 millimeter, or no fragment at all? What is the problem with the fragment size? If we take 4 millimeter as a cutoff, then most of the literature or most of the publication, they report that the stone free rate can go as high as 95 to 97% these days with the use of suction. At the same time, if we consider stone-free criteria as zero fragment or no fragment at all with the use of CT scan, then the stone-free rate can drop as low as 42% in various studies. So the size of residual fragment to define stone-free rate is very, very important, and it gives very large range of stone-free rate after stone surgery. It's very important. That's why we need clear definition of residual fragment size to term or to coin patient stone-free. Another very vital questions when we talk about stone-free rate is timing of imaging. There are various reports of imaging after stone surgeries, and there are very interesting findings across the globe that I'll share later in my slides. When generally urologists they do imaging, how frequently or how they are doing imaging after stone surgery. So this is another field that lack consensus when we talk about stone free. Most of the people they do imaging after week or weeks after stone surgery, most commonly done. But there are reports when any one modality of imaging is done at day one or even after 1 year. So the time frame is again very, very long. So we don't have consensus on that. But the problem with timing is stone surgery or stone disease, it's very peculiar. It's not like stone in gallbladder, The unique feature or very peculiar characteristics of urinary stone disease is the chance of spontaneous passage of the stone from urinary tract. So I think the variation of timing to assess the stone-free rate is because we are allowing some fragments to pass spontaneously, and we are trying to avoid unnecessary intervention, or we don't want to overtreat the patient thinking that the stone free is not very good. So spontaneous passage of the stone is very unique features of urolithiasis. So let's see something on stone spontaneous passage of the what literature says. If we leave fragment less than 4 millimeter after stone surgery, then the spontaneous passage from the kidney is possible in one third of the patient within 1 year. So if the stone fragment is more than 4 millimeter, then it decreases the chance of spontaneous passage less than 10% even for 3 years. So as we know, most of the literature, they take this cutoff of 4 millimeter fragment size, I think, based on this probability of spontaneous passage of fragments. I think this is quite justifiable. This cutoff is quite scientific for now till we get newer evidences. We still don't have much of evidences, but there are a few evidences of spontaneous passage of stone fragments from kidney. So if we look closer on those less than 4 millimeter fragment again, and if we follow up them for like 4 years, then the chance of spontaneous passage remains same. One third patient will be stone free, but the progression is again possible in another one third, and one third of patient will need I mean re-intervention, one or other intervention after stone surgery. So what does that mean? It is, I quoted this from the very fresh data from EAU guidelines. What does that mean? That means even less than 4 millimeter of fragment size after stone surgery is not safe. As high as one third of the patient may need re-intervention even if we leave fragment of less than 4 millimeter. So timing, we were talking about the timing. So what is the ideal timing? There is no ideal timing. If we do assessment very early, less than two weeks, then we overcall failure, right? We may detect those fragments or dust which are very high likely to pass spontaneously, or which will not require any further intervention. We will pick them up, we will stress out ourselves, we'll give some stress to our patients, which is not necessary. It's something like I would compare this scenario like PSA screening for prostate cancer. In early 80s, there was a time when everybody was screened for prostate cancer, especially in America. Later, it was found out that it only induces overtreatment and it is completely unnecessary. Something like that. If you do imaging after stone surgery too early, then it adds stress. It doesn't add advantage much, because uh, it will compel us to overtreat those unnecessary dust or fragments. But unless, if the patient is symptomatic, or if there is any complication like increasing hydronephrosis, or if there is a pain, fever with those smaller fragments, then I think early assessment should be done. Otherwise, early assessment should not be done, especially with PCNL and flexible uteroscopy. Not only that, most of the stone surgeries are followed by double gestanting, and those double gestants are kept generally for 5 days to 2 weeks, depending on the geographical variation, depending on the surgeon preferences and various reasons. For 5 to 2 weeks, there will be some kind of stent or drainage in most of the cases. If you see larger stone database paper across the world, then we see that the stents are generally placed. Majority of the surgeons, they prefer placing stents, and they are placed from 1 days to 2 weeks max. So sometimes 4 weeks. So in presence of double stenting, if you do imaging like ultrasonogram or simple X-ray KUB, then it's not very sensitive for assessment of residual fragments. That's another reason why we should not do early assessment of uh, residual fragments. The third reason why we should not do early assessment is in presence of double stent in situ, it will also aid passing those small fragments, right? So when the stent is there, then there is some chance that the ureter will get dilated and it will aid to pass the some residual fragments. That's why stone-free assessment or imaging should be done after removal of double stent if you have placed one. That's why I would say the sweet spot is 3 to 4 weeks, or after 2 weeks to 4 weeks is the right time to do imaging. Generally, it's called post-operative imaging. It's not follow imaging for need of reintervention and progression of the stone fragments. It's for the surgical success or evaluation of the stone free rate from particular surgery that was done 3 to 4 weeks back. So sweet spot is 3 to 4 weeks after removal of double gestanes. And yes, most of the endourologists across the world, they are doing stone free evaluation at this interval of time because it balances spontaneous passage versus residual fragments. This is very interesting finding. This is a report from United States of America when the subsequent 1 lakh patients were evaluated. The data from 1 lakh of patients were evaluated. They found that more than 55% of the patient, they don't undergo any kind of imaging after stone surgery at 3 months of time. No imaging at all. So if you check them for 12 months, more than 1/3 of the patient, they don't undergo any imaging after stone surgery, so which is not acceptable. So the timing of imaging, or even to do imaging or not after stone surgery, is very heterogeneous among the practicing urologists across the world. This is from a very developed country. I am sure the imaging pattern, the imaging tradition or follow-up imaging in developing country like ours is not different from the one they found in 2018 from University of Washington. I think we have similar or maybe worse pattern. The third question, what is the problem with stone-free definition, is the modality of imaging modality, or the radiological tool that we use to assess the stone-free rate. There are various tools like ultrasonography, plain X-ray KUB, or combination of ultrasound and KUB, or non-contrast CT KUB to assess the stone-free rate after stone surgery. As we all know, these tools are very different. These tools have very variable sensitivity and specificity when we talk about stone disease and when we talk about small stone fragments. We know that the ultrasound is not very sensitive tool to pick very small stones, especially in the ureter. And X-ray KUB cannot pick the stone fragments less than 2-3 millimeter in size. But these are the most commonly used radiological tools for the assessment of stone-free status, not CT KUB. We as a surgeon, we like to assess the stone-free rate endoscopically very much, especially the RIRS surgeon. We do good dusting and we say it's a stone, the stone is clear. So endoscopic assessment of stone-free rate, how good is it is. There is a very nice report in 2023, endoscopic assessment of stone-free rate by surgeon was compared with the residual fragments in CT scan, and it has shown that the sensitivity of endoscopic assessment is strikingly low. It's less than 25%. So endoscopic assessment of stone free is not very reliable one. So what we are left with, we are left with very commonly done radiological assessments like ultrasonogram, X-ray KV, and non-contrast CT. All these modalities have their advantages and disadvantages, cost, the radiation dose, sensitivity, etc., etc. The ultrasound and X-ray QBs are not very good, but unfortunately, these are the most commonly performed radiological imaging for the assessment of residual fragments. What EAU guidelines says is at least one low dose non-contrast CT scan should be done in first 1 year to assess the stone free rate. But see, this is the reporting status again from the same paper 2018. Ultrasound, CT, and X-ray KB are equally done for the assessment, whereas significant number of patients, they don't undergo any imaging for residual fragment assessment. We know there are various types of CT scans and non-contrast CT. Since the urolithiasis is very recurrent disease, they need to undergo CT scan time and again. We are very concerned about the radiation dose of various CT modalities, especially CT IVU. That's why it is recommended that non-contrast CT should be done at the low dose, because the radiation exposure with the non-contrast standard dose non-contrast CT is around 6.5 millisievert, whereas low dose gives half of that, 3.5 millisievert. And there is another low dose modality called ultra low dose non-contrast CT, which will give near about 2 millisievert of radiation. But unfortunately, less than 8% of the CT done for urolithiasis are done in low dose protocol, even in the developed countries. So most of them are done with the standard dose non-contrast CT scan. CT scan evaluation of the stone and residual fragments are done in the soft tissue window, but the stone is not soft tissue, right? To delineate more details on the stone fragility, stone size, and especially post RIRS, if you want to characterize the fragments or dust precisely, then bone window is more preferred, because bone window will give more details on the stone fragments and dust. It will differentiate stent from the stone, and the measurement of small residual fragments are more accurate with bone windows than soft tissue windows. So if we are doing residual fragment assessment with non-contrast CT scan, then it's better to ask for bone window. It's not very difficult. It's just a software issue. So you can ask a bone window for proper assessment of residual fragments. So although we have seen that only 8%, less than 8% of the CTs are done in low dose protocol, and most of the residual fragments are assessed with ultrasound and X-ray KUB. Recently, Journal of Endourology, they have mandated that reportings of all the stone surgery outcomes should be done with non-contrast CT of 2 to 3 millimeter cuts. Then only the publication will be accepted in Journal of Endourology. That's why lots of manuscripts are being rejected since we don't report our stone free in with the uh, CT scan. That's why the time is changing now, and they have proposed a grading of SFR, and we have published a couple of our work in fans collaborative group and flexer using this grading system. And I think although radiation is an issue and we don't use low dose protocol much, I think CT scan is being used more frequently across the major hospitals and especially academic centers to report the stone free rate. There is very interesting. It's just a proposal from Bhaskar and group in 2014. It's a little old paper, but I found it very interesting. He proposed that the stone free rate should be reported as a very different way. You know, if you use ultrasound, then you should, if in ultrasound, if you find 1 millimeter residual fragments, then you should report as 1U. If you find 1 millimeter in CT, then 1C. You know, it's little complicated and it's little detailed, but this is the one very different way of reporting that I found in literature. But again, this was never used. I just saw this paper while I was going through this presentation only. So another very interesting, I think this may have some future for the reporting of stone free rate. It's from Olivier and group. They think that even residual fragments, not only stone size, you know, even residual fragments should be reported in volume based format. That means VSFR, because they think that if the residual fragment is 2 into 1 into 1 millimeter, it's a 2 millimeter cube residual fragment, you know. If but the same size 2 millimeter, if it is 2 into 2 into 2, then it's 8 millimeter cube. So the volume of those two residual fragments is 4 times different. And they think that the difference of 4 times in this volume can cause the symptom, it can cause need of reintervention, and it can cause future renal damage. So on the basis of that, we still don't have anything on volume based stone free rate, but this has come up. Okay, so although we still don't report primary stone burden as a volume, lots of talks are going on regarding need of reporting of volume based stone size in literature, and maybe in future guidelines I think volume will come instead of size. The need of volume based SFR is also coming up. So when we talk about stone free rate, I think the recent advancement in endourology about suction in endourology also plays some role, because we have seen that in last couple of years with the introduction of suction even in PCNL, mini PCNL, and flexible uteroscopy, that there is some improvement in stone free rate. I would say we still need more robust data. We still need RCTs or larger study. We have, database publications on suction. We have very large, huge database publications, but we don't have much RCTs on the role of suction in uteroscopy. Of course, we have a couple of RCTs coming up, and they have shown that suction has played a and very important role in enhancing stone free rate after uteroscopy. But unfortunately, when I think Chandra is also there in this paper, we published it in European Urology Focus in 2024. We used fan sheet for ureteroscopy and assessed stone free rate with CT scan at day 30. And the stone free rate, zero fragment stone free rate was only 57%, which is not very high, you know. Uh, So it's not very encouraging that.
But some people are reporting even 100%
Yes,
stone-free rate with fans. Some
yes,
papers are
yes,
there even by
yes, I agree. Yes.
100% after 1 month.
So what do you think? What do you think? What is your experience? Can you achieve 100%
No,
stone-free
no,
rate
no,
with
no,
fans?
100% is not at all. If the
Okay.
number of the cases is more than 100 at least, stone cases should be at least 100. 100 cases if you do, 100% achievement for me is not able to accept. But in my cases, I don't think 100% is there.
I agree with you, Chandra. So yes, suction is adding something. I think suction is again improving day by day. There are different technology of suction. There are different accessories for suctions, irrigations. Now we call fluid dynamics, and various modifications are coming. I am sure suction will give us better stone free rate, but to achieve 100% zero fragment rate with suction is, I think, I think at this point of time it's still um,
Debatable,
yeah, debatable, and it's still difficult for us.
difficult.
But if we consider less than 2 millimeter of fragment as a stone free rate, then
Okay,
the stone free rate after suction ureteroscopy goes strikingly high. It's as high as PCNL. It's
correct,
97%.
correct.
So this is the only video that I have for presentation today, Chandra, because I know
Okay.
pure urology is a video-based presentation. Unfortunately, the topic we decided today is something very
No problem.
theoretical.
Lot of
Theoretical,
finest aspects are getting discussed. Future will
yeah.
be like that. Super, super specialty it will become.
So the video at the left was the video few months or few a couple of years back. We used to be very happy after we achieved that dust at the end of ureteroscopy. We still do dusting like that, uh, and we call it as a stone free rate. I mean stone free procedure after the at the end of the surgery. But nowadays, with the introduction of suction sheath or a suction scope, we suck all those fragments and dust, and we make pelvic calyceal system with free of those dusts and fragments, and we call the definition of stone free rate endoscopic stone free status is being changed nowadays. So again, I want to come back to zero fragment rate. Recently, our friend Gauhar has published zero fragment is getting real nowadays with the introduction of suction in endourology. I think yes, as you said, as you just said, if your number is very low, if you are evaluating very limited number with a experienced hand and stone size is small, then you can, of
Yeah,
course, you can achieve a zero fragment rate, and that's not our aim. Zero fragment after any procedure, any stone surgery should be achieved by all, majority, I won't say majority, all, by most of the endourologists with a limited number of accessories and technology. I don't think any stone surgery should be super I mean, complicated. It should not be the stone surgery should not be heavily technology and instrument dependent, because it won't be popular. It won't be available in all part of the world. It may be confined to some center or some surgeon, but it will never be available for every or most of the urologists. So it should not be over exhausted with resources. I mean, if you are using like 10 15 accessories or 10 15 kind of resources just to achieve zero fragment rate, then I don't think it will go a long way. That's why zero fragment rate may be possible, but it's not easy. Again, if you target zero fragment rate, and if you increase morbidity by using lots of technologies like heavy irrigation or larger access sheath or something like that, then it's again, it won't be acceptable, or it won't be popular, so it will not go long way again. So zero fragment rate should be taken cautiously. We need zero fragment rate, as we have seen that even smaller residual fragments can give problem and may need reintervention in the future. Zero fragment rate is good to achieve. We should always target to achieve zero fragment, but it's not an easy job for now. So why do we assess stone-free rate after stone surgery? Because we are afraid of doing another surgery, or we want to know whether the patient will need reintervention or not. Again, we come back to same cutoff, less than 4 millimeter or more than 4 millimeter. What EAU guideline recommends is, if the residual fragments is less than 4 millimeter, then you should not rush, because 66% will not require reintervention. Only one third will require reintervention. So reintervention is not urgent if the residual fragment is 4 millimeter and less, but you have to do follow-up imaging at least for 4 years. Whereas if the fragment size is more than 4 millimeter, then you should plan reintervention immediately, because the spontaneous passage rate is very low. So this is the follow-up protocol proposed by new EAU guideline. They have mentioned some safety margins of 80%, 90%. It's little complicated, but to make it simple, if the stone is radio opaque and if you have achieved stone free, then also you have to do imaging for at least 2 years. If it is radiolucent, then for 3 years. So if you want to play little safe, then at least you have to do imaging for first 5 years. And if you have left residual fragments, then the cutoff is again 4 millimeter in size. If the patients are high risk, then it should be associated with medical treatments, and the follow-up should be little longer. So I'm coming to the end of the presentation. We have some lack of consensus when we talk about residual fragments, because stone-free rate, because of the very undefined criteria of residual fragment size, which imaging modality to use. Although CT scan is the gold standard, we have radiation issues, we have cost issues with CT scan. We need repeated. So one scenario, if you have a 5 millimeter residual stone at the 1 month, if you have done CT scan, after 1 month, then how do you follow up? Do you want to do CT scan again for 5 millimeter residual fragment, and how frequently? We don't know that. There is no guideline and there is no recommendation. So imaging modality is again a confusing part when we talk about stone free rate and timing. But in timing, I would say 2 to 4 weeks is the right time to do imaging for the assessment of stone-free rate. So what we have, these are the confusion, but what we have when we talk about stone-free rate, what we have some degree of consensus, that is post-op imaging for stone-free rate should be done at 2 to 4 weeks. Low dose non-contrast CT scan at least should be done once after surgery, because ultrasound and X-ray KUV has a very low sensitivity for the assessment of low stone-free rate. For the high-risk patient, the timing, the modality of imaging, all should be tailored, and consider reintervention for residual fragments more than 4 millimeter because of the low spontaneous passage, high need of progressions, high chances of progressions, and high chances to need that it will require some reintervention. Of course, aim for complete clearance if possible, which is not always possible. Maybe with the introductions of newer technologies and improvement of newer laser technologies and suction, we will be having better and higher complete clearance after stone surgeries. Thank you. You are muted, Chandra.
Let us have some discussion.
Yes.
Because a lot of people think these are subjects are dry topics. What's happening is already 100 people have listened. Once we go into super specialty, the presentation will be like this. I must appreciate that you are going into the minute level. If my own relative is there, the patient himself will go into these minor details. That is the future. If you are sticking to the stone, if you are treating stone disease too much, bread and butter surgery, then every patient will ask what happened to my 4 mm inferior calyceal stone after 1 year? What happened to my 2 mm? Some may go to court. Now let us discuss with Anil common things. My first question, Anil, you have seen PCNL, you know how to do very good PCNL. You have seen RIRS with Flex X2 with normal sheath. You have seen sheathless RIRS. Now you are doing fans RIRS. In all the things previous days, we used to dust to the finest dust and then leave. People like Ravindra Sapnis sir says, Chandramohan, if you make finest powder and leave, there is no need to do suction. But what I and you probably feel that whatever the powder, small fragments, if you suck it out, we feel good that kidney is emptied. My question is, will you do the dusting with fan sheath as much as possible, or you will fragment and do popcorn? A single stone 1.5 centimeter. I hope.
I think this is a very pertinent questions, and it again depends on the individual, Chandra. If you ask me personally, I always go with dusting, even
Great.
with fans.
I
I
also say
do,
the same.
yeah, I do begin my flexible, I mean RIR surgery like before fans era. I do dusting. I
Yeah.
start with dusting only.
Yes. Fine
Okay.
dusting you do.
Yeah, fine dusting always. But unfortunately, in last WCET in Phoenix, I was visiting industry booth, and I was observing fans booth, one of the fans booth, and we were discussing. And one very young urologist from America came, and we discussed about the use of fans. And then I said, we were discussing how we use fans for optimum result. Uh, the same question he asked me, like you said. I said I do dusting because it will, for me, it will decrease the, I mean, operating time, right? Because if you
Correct.
do dusting, the dust will come out, and
Correct.
at the end, only very few fragments that you have
Correct.
to suck
Very
it out.
important point. I want this
So
point only.
yeah, so very few fragments. Uh, if you remember pre-fans era, Chandra,
Yeah.
at the end we do popcorning, so-called
Yeah.
popcorning. So those fragments which we do popcorning are only to be sucked out with fans,
Yeah.
right?
Yeah.
So
Yeah. Yeah.
if you
Exactly.
so then after meeting that urologist from, I came back from Phoenix, and then I thought, why don't I try primary fragmentation with fans? Because what I think is in smaller stone, Chandra, I agree to, I mean, disagree that in smaller stone, like 7 8 mm or less than 1 centimeter stone, I sometimes do fragmentation primary
Because
and
four,
make it
five
like,
fragments you can suck it
yes,
out.
yes. So it depends on individual, it depends on the stone
So,
size.
don't say.
But if you ask me what is your primary I mean preference, whether primary dusting, suck out, and do minimal fragmentation suck out, then that will be my option.
My second question. PCNL favoring surgeons over the inferior calyceal stone. We also do PCNL. RIRS we do in inferior calyceal stone. What is your present feeling when inferior calyceal stone is after how many millimeters, after how much difficult you do PCNL? You are a both surgeon. You are a PCNL surgeon, you are a RIRS surgeon. More so RIRS. But when will you choose a common question I'm asking to improve the stone free rate? Will you try go and see the angle and see the stone and decide, or RGP and decide, or CTR decide? How do you decide inferior calyceal stone?
So again, uh, inferior calyceal stone is a different entity, even for experienced
Yeah,
RIS surgeon. Forget about PCNL. PCNL, inferior calyx stone doesn't matter much. So when we do flexible uteroscopy for lower calyceal stone, what factors I consider? That was the question, right?
yeah,
Of course, uh, stone size is the big determinant.
yeah.
I go up to 22 millimeter, sometimes 25 millimeters lower
I go up
calyceal
to
stone.
20.
Yeah.
Correct.
So I don't measure anatomical details like IPA, width, length. I don't measure in any cases. But if the lower callus is very much parallel to the spine, like this,
Yeah,
the
yeah, yeah,
stone axis is, this is the spine, and if the this is the spine, and if this is the axis of the stone,
yeah,
and the burden is too much, then you anticipate that it will be difficult flexible uteroscopy. One, apart from burden of the stone, right? Uh, when we do lower pole uteroscopy, it's not only calyceal anatomy or IPA, it's the status of upper ureter also, if and the VUJ, if you have already narrowing at the distal ureter, if the there is a kinking of the upper ureter, again you have, if there are lots of friction for the scopes and fans, then the access to the lower pole will be difficult, because the access of the lower pole with the flexible scope is not only deflection, it's a torque of the stroke. The movement you do outside the kidney should reflect inside the kidney, right?
yeah, yeah,
So the factors that will hinder the access to the lower pole is the multiple friction point of the scope
yeah.
and the sheath inside the pelvic calyceal system or
Correct.
ureter,
Yeah,
so if the prostate is very high, again VUJ is very tight, PUJ is very narrow, then you will have difficulty assessing lower
difficult.
pole. So
Correct.
all
Okay.
these factors should be considered, I think.
Okay.
but but I will use fans for lower pole. We
Yeah,
have published efficacy of lower pole with the fans. I think you are there
yeah.
as one of the co-authors, and the result, I would say, the benefit of fans is, I would say, slightly,
More.
it is more in lower pole.
And extension of this question, I want to ask you, when you go lower pole, there are three ways you can use the fan's access sheath.
Yeah.
One is keep the fan sheath in the upper ureter, go to lower pole, finish aram se all the work. At the end, you pass and suck out the fragments is one option. Two option is keep in the pelvis so that outflow will be good and dry, but flexion is a problem. Third option is take the sheath also along with you. Nowadays, people are saying that we can bend also sheath into the lower calyx, but lot of people are complaining that flexible scope is getting damaged. So what is your comment on the usage of the fan sheath, how you use this modality in the
Yeah.
inferior calyceal stone?
Yeah, I totally agree, and you have already mentioned my favorite trick, not to keep tip of the fan sheath in the pelvis while you are accessing lower pole.
Yeah,
Don't do that.
yeah, yeah.
Never do that. It will, even if you have a very good deflecting scope, you will have difficulty going to the
Yes.
lower pole, because
It will
I would
hold.
say, yeah, I would say it will make artificial steep IPA, The
Yeah,
IPA will be more steeper with the access sheath inside the renal pelvis. So
yeah.
just pull it out just below the PUJ, go inside the lower pole, do good dusting, do
That
good
is very important
dusting.
point that
Yeah.
the
And for the introduction of the fan sheath in the lower pole, you can use sheath advancement technique. Of
yeah,
course, if you are using reusable scopes, then it's a matter of concern. Yeah, I agree. I agree. I would say with the introduction of fans, in my practice also, there is slight increase in scope damages.
yeah. For fifth question, in our private practice in India, majority of the urologists, after doing a good RIRS, we don't do CT scan in the follow-up normally.
Mhm.
Sometimes we don't do ultrasound also unless the patient complains. what is the recommendation by the guidelines that you have done 1.5 centimeter stone? Nicely you have done, stented, removed, patient does not have any complaints. Sometimes we do ultrasound on a OPD basis, just see whether everything is okay. But generally, after stent removal, they will go home, they will not come back, and that's all. What is your opinion?
So my opinion is slightly different from what guideline recommends, or my practice is, because the what guideline recommends is still not very practical for everyone, especially in constrained countries like ours. What guideline says is after stone treatment, after PCNL and uteroscopy, at least one NCCT should be done, preferably within 4 weeks, preferably within 4 weeks, or if everything is all right, within 1 year.
Okay,
NCCT recommendation is NCCT.
okay,
But what I do is I don't do CT scan routinely. I don't do routinely. I have done CT scan within 30 days for the purpose of
paper,
research. Yeah,
research.
research, and for some high risk patient, for patient specific reasons, but it's not a routine practice for me.
Oh, it is said that after doing one RIRS, lifelong ureter will be nice for the RIRS. Even after 1 year, 2 years, 3 years.
Mhm.
So, in a patient recurrent stone formers, benefit of doubt, will you do more RIRS in his lifetime? Is it safe? Or will you do more PCRL? Is it safe? Multiple, for example, in Nadiad, they say that one patient in their lifetime comes 5, 6 times sometimes, recurrent
Mhm.
stone former. 5, 6 times, if you wanted to do stone surgery, what do you think, RIRS or mini per, which is safer?
So if you can clear the stone with RIRS, definitely RIRS is better, because
RIRS.
you are not puncturing the kidney, right? Once you puncture the kidney, there are so many, I mean, complications and risk associated with it. So, but I don't think once you have done RIRS, the ureter will be, I mean, accommodative lifelong, because there are another school of thoughts. They think that if you do RIRS, you are creating stricture. So there is another school of thoughts as well. But
Right.
if you can clear the stone with RIRS, I think this is the preferred modality to treat the stone.
Root the stone. Okay. If if you are doing RIRS for any ectopic kidney, have you used fans access sheath in ectopic
Wow.
kidney?
So this is ectopic questions, Chandra. So people think that anomalous kidney, Harshu kidney, malrotated kidney, pelvic ectopic kidney, or cross-fused ectopic kidney, these are very good cases for flexible
RIRS.
uteroscopy. Yeah, but it's not 100% true, right? In terms of access, yeah, you can go, but the calyceal orientation, right? I have done a number of pelvic ectopic kidneys,
Yeah,
not
yeah,
very big stones, like 12 stone. Initially, I thought I'll just go in, and
yeah,
after 30 minutes I'll be out. No, it
yeah.
won't be a very, very straightforward, but
PUJ,
yeah, there will be, I mean, the anatomy of the PCS will be different.
yeah,
PUJ will be narrow,
yeah.
and your orientation will be completely different. So, to answer your questions, most of the all anomalies, anatomical anomaly of the kidney, I generally pre-stent, Chandra.
Okay.
Regular cases, I don't
I
pre-stent.
also do the same. Exactly.
Yeah.
Very good point.
So pre-stent, use the fans, because the drainage in anomalous kidney is not normal. So if the drainage is not normal, then even if you do good dusting, there will be some residual.
Yeah,
So
yeah.
roll of
Right.
fans is there.
Where
Roll
roll
of
of
fans
fans
is
is
there.
there. Especially if PUJ you can cross safely.
Yes.
At
Yeah.
least suck the powder at the end.
Yes.
Replacing with fan sheath, even if it is at the end, just to
True.
suck it is good enough.
I have done that a couple of times, Chandra.
Yeah,
I tried passing 10, 12 fans sheet in young male recently, 1 month back. I could not. I did
normal.
sheetless dusting. I didn't want to leave that dust. Then
Yeah,
I took 8.5 FR fan sheet.
yeah.
I introduced it. sucked all the dust with 6.3 and came out.
At the end, you can do that. By
Yes.
that time, ureter also will get dilated a little bit.
Yes. Yeah.
Yeah. Last couple of questions. In routine practice, contrast enhanced CT, is it recommended in, for example, Nadiad submitter says, we do all cases CECT, but I don't do if ultrasound does not show any abnormality. I do only plain CT scan. What is the general practice in Nepal and Bir hospital and your opinion? And worldwide, you are so many good friends who are pioneers in stone. Will they do contrast enhanced CT for all stones?
You mean contrast enhance for the assessment of stone or for residual stones?
No, for the stone, normal stone.
Stone. Okay. So, as you must have noticed that the stone disease is getting smaller these days, right? Earlier, we used to have bigger stones,
Yeah,
latecomers. Now, even in this part of the world, our world also, ultrasonography is readily available. So
yeah,
patients come, they come early. So most of the stones, they are not very big. The if When I do contrast is when I need functional assessment,
okay.
moderate or severe hydro, or if I suspect any anatomical abnormalities like
Abnormal.
ureteric stricture or any anatomical
Bifid system,
detail.
something like that.
Yeah, any anatomical detail if I need. Regarding contrast, I don't think we need contrast if there is no hydro. If there is good parenchyma in ultrasound and in contralateral and ipsilateral kidneys, because it doesn't add anything, one. Or second, contrast CT is not only contrast nephropathy, it also adds lots of radiation.
Yeah,
When
yeah,
we do CT IVU, the dose of radiation goes tremendously high. So
yes,
I
yes.
don't routinely do contrast for evaluation of stone.
Last question. Uh, when you do RIRS, when you have done nicely, you don't do relook. What are your indications in private practice for relook? When will you do relook? Because it adds cast, it adds anesthesia, it gives insecurity to the patient. If you put stent, it will become 4 surgeries to the theater. Some amount of we also feel bad to do relook, but large volume stone, something like that. When we in routine practice to see these insignificant stones cleared or significant stones to be cleared, when will you do relook? And additional question, are you using the baskets? If so, where? These are the last two questions.
Okay. So relook surgeries, it's not very common in my practice. Today I did one relook surgery. It was of middle-aged female with some bony abnormality. The kidney was uh, inside the rib cage.
Okay.
The space was not much because of the bony abnormality. PCNL was not possible, and that patient was attempted PCNL in some center, tried RIRS. It was a big lower pole stone. Tried RIRS by some surgeon, failed, and she came to me. The stone burden was quite substantial in that patient. So, right from the beginning, I said I want to pre-stent this patient. I pre-stented because it's a special case. Then, in that case, I did fans. The stone burden was quite high. So I did, as you said, I did dusting. Then I did good fragmentation. I
Okay.
didn't aim for stone free rate in that particular session. I knew that that lady will need relook.
Okay.
Same applies with large burden stone free.
Large button.
Large burden. I intentionally plan for redo surgery or reintervention, and I talk to patient accordingly because if they don't want re-intervention in large burden stone, then I
PCNL.
offer them PCNL.
Correct.
So, large burden, abnormal anatomy, we sometimes need to plan re-intervention beforehand.
Correct. And extension of that question is, when will you use the last question about the guide wires to decrease the SFR? Sorry,
Basket.
baskets, basket.
Basket. So the use of basket has decreased a lot with the fans nowadays, but I still use a basket sometimes in lower pole. That's not because of the accessibility. That's because of the ergonomics. I don't want to, I mean, operate like in this position or this position for
For a
one and a
long
half
time.
hours. Yeah.
Yeah.
So for my hand or for life
Both.
of the scope, I usually relocate one. And most of the times, the stone samples can be achieved with dust and fragments with fans. And of course, the use of basket has come down tremendously less.
Yeah. So with this, though I have asked some questions which are practical because a lot of 121 people attended. That's why I asked these questions. But otherwise, you concluded that stone size 420. You concluded that plain CT better. Ultrasound also can be used. You conclude that time duration, we should not be in hurry,
Yeah.
unnecessarily over treat the patient. Multifactorial, better to counsel the patient when you do these surgeries, especially when we do for 8 mm. If you have 4 residual by chance, they will ask half
Yeah.
of the stone you have not removed. And they sometimes will be very unhappy. So be careful about this. But I think fans in my or your view decrease the stone free rate as well as the infection, provided you take care of the ureter and stent the cases appropriately. Overall, this year significant changes are happening. You are actually given topic previously also about the pressure. You have a lot of experience on pressure, how it increases, temperature. So in future, it won't stop here. I think you agree that we will be careful about the pressure, temperature, stone free rate, and complications. Minute details will go. Lot of papers are published. You have also published this year around 4 or 5 papers in collaboration with everyone. Wish we will try to give the best to the patient with these things. And your presentation was too depth. Not many people think what is there 4 mm, 2 mm like that. But after 10 years, these presentations will be given more importance because we are going nearer to perfection. Naturally, science is developing, we are going nearer to perfection. Every slide you focused too detailed about every minor point. Good, and I'm very happy that you accepted and you focus and you become already you're pioneer in RIRS and fans this thing. I think you will continue your research work and be role model in stone treatment for the society. Thank you very much.
Thank you, Chandra. Thank you for having me.
One question has been asked, sorry. Good
Okay.
evening, sir. You mentioned 4 mm as significant residual stone size for re-intervention. Will you consider 4 mm as cutoff for ureteric stone also for re-intervention? Is the question. If the 4
Yeah.
mm is in the ureter after stent removal.
Yeah. So it again depends. Ureter is a different location. So it depends which part of the ureter. If the lower ureter, I don't think you need to do re-intervention for 4 mm in lower pole. You can observe the patient, give analgesics. If the hydronephrosis is not increasing, then the re-intervention is not necessary. Again, it's not only residual fragment size, the symptoms of the patient, the grade of hydronephrosis, presence of infection, all this should be taken care of.
Yeah. Okay. Next question. One more question. Namaste, sir. I am in the very early days of my urology training. So please forgive my naivety. What do you think is the ideal number of RIRS to be done to master the learning curve of RIRS? Okay, good
I
question.
think I think Chandra will answer this question.
No, no, no. You
There,
tell.
no,
This is a question for.
there are. I can't. I mean, give you a number, but there are research from Japan Ito Group. They have research that it is a little older study. I think it's published in something 2010 or 12. So they have said that to have a good to learn a good skill of flexible uteroscopy, at least 50 uteroscopies should be done.
Very good.
50 uteroscopies should be done
So
at
if
least.
any center can give you in 6 months to 1 year,
Yeah.
50 cases, lifetime you
Then
can learn that surgery. If for
yeah.
all you are interested, go to a
Yeah.
center where 50 cases in 1 year, if you can do independently, I think your answer is logical, even in my experience, because I also train people.
But
So,
Chandra, when I was, I mean, going through this presentation, well-known surgeons from America, North America, that he reported stone-free rate from the surgeons who have done more than 5 ureteroscopies, you know. So 5 ureteroscopies is too less to report
No,
us.
no, no. I don't think so. 50
Yeah,
is a good number. 30 to 50 is okay. If you
yeah,
are
50
new and skill
ureteroscopy.
also, the 50 is fair enough.
I think after 50 ureteroscopies, your confidence level
Yeah,
will be, I mean,
100%.
you will encounter different stones, different location, different size, and
Yeah.
your skill will be, I mean, better after 50.
Same person has asked, approach to bilateral stone. Do you do bilateral RIRS in the same setting, especially in low volume burdens, or are you in second setting?
I routinely do bilateral, but I go with the simple or easy side first. If it don't promise your patient that you will clear both the side at the same sitting. So I do one side, easy side first. If it goes well and good, very smooth, no problem, then I generally attend bilateral flexible uteroscopy.
Sure, very good. Thank you very much. Fantastic.
Thank you, Chandra.
Great presentation.